Hello everybody. Today we are going to discuss about the weaning failure. This was also the question which was asked in DRNB critical care exam in April 2024. So weaning failure is defined as failure to pass an initial trial of spontaneous breathing or requirement of re-intubation within 48 hours of extubation. Some authors considered up to 72 hours of defining weaning failure. Extubation failure of any cause will also be included as a weaning. So weaning failure has been classified as per following classification. That is simple weaning. Simple weaning is patient who are successfully extubated after first SB. Difficult weaning is patient who failed initial SBT and require up to 3 SBT or up to 7 days from the first and initial SBT for liberation from mechanical ventilation. Prolonged weaning patient who require more than 3 SBT or more than 7 days from the initial SBT. So for the weaning failure is elderly age greater than or equal to 65 years, cardiac failure, presence of other comorbidities than the cardiac failure. Primary indication for intubation being pneumonia, patient who have already failed 2 or more consecutive SBT, those who have baseline PaCO2 of greater than 45 mmHg at extubation, and Apache 2 score of greater than 12 on the day of extubation, poor cuff reflex, stridor and the upper airway obstruction at extubation. So causes of weaning failure is respiratory cause, unresolved primary pathology, increased work of breathing, bronchospasm, narrow ET tube, inappropriate ventilatory setting, and increased secretion and retained secretion. CNS cause include sedative paralytic agent, reduced neural drive, delirium, critical illness, myopathy. Cardiac cause include heart failure, myocardial ischemia, diastolic dysfunction, weaning-induced cardiac dysfunction. Electrolyte and endocrine related causes include metabolic alkalosis, hypokalemia, hypomagnesemia, hypophosphatemia, endocrine disorder like hypothyroidism and hypoadrenalism. Diaphragm related causes include ventilator induced diaphragmatic dysfunction, diaphragmatic weakness, and paralysis. So let's see each and every cause in detail. About airway and lung dysfunction, elevated airway resistance, reduced respiratory system compliance, and impaired gas exchange increases the work of breathing and as such contributing to the weaning failure. The most prevalent causes of the impaired mechanics are increased airway resistance, that is may be related to the tube, central airway like tracheostomy malposition, sputum plug, corpus elenium, that is after trauma, tracheomalacia, and tracheal stenosis. Then smaller airway as occur in the asthma, COPD, acute respiratory distress syndrome, reduced chest compliance as seen in edema, elevated abdominal pressure, pleural fluid ascites, obesity, and the lung related like intrinsic PEEP, alveolar feeling like edema, pulse collapse, pneumonia, and interstitial lung disease and fibrosis. Now, resistance in the weaning. Resistance of upper airway should be considered in difficult weaning. Rumack and the colleague found that tracheal obstruction caused by tracheal injury may contribute to weaning failure in patients who were on invasive mechanical ventilation for more than 4 weeks. Tracheal injury include tracheal stenosis, tracheomalacia, and granulation tissue formation. In intubated patient, endotracheal tube could increase the airway resistance. Indeed, resistance of endotracheal tube removed from the patient is significantly higher than resistance of the new tube when tested in the lab setting, and this is due to contamination of the tube with the airway secretion. No correlation between duration of intubation and resistance of tube was found. However, in general, it is misconception that after extubation, upper airway resistance decreases. In fact, the work of breathing in patient mechanically ventilated for more than 5.5 days increased after extubation, and this increase was probably due to the edema of upper airway. Increased resistance of smaller airways is characteristic of chronic obstructive pulmonary disease and asthma, but has been demonstrated in ARDS. The later increase in ARDS, the increase was due to edema of bronchial wall. Increased airway resistance is associated with development of intrinsic PEEP. Intrinsic PEEP develops if expiratory time is shorter than the time needed to empty the lung due to elastic equilibrium volume of total respiratory system. Accordingly, intrinsic peak may develop because of the increased flow resistance, expiratory flow limitation, high breathing frequency, loss of elastic recoil of lung. Indeed, in COPD patient with weaning failure, intrinsic peak is higher compared to those who successfully weaned. Intrinsic peak acts as inspiratory threshold before inspiratory flow can be generated and result in elevated work of breathing. In addition, pulmonary hyperinflation resulting from intrinsic peak places the diaphragm at suboptimal position on length tension curve, impairing the ability to generate negative pressure. So the intrinsic PEEP is associated with patient ventilator asynchrony and in particular with ineffective triggering. So recently, David and colleague showed that in patients with high incidence of ineffective triggering, duration of mechanical ventilation is significantly longer compared with patients with low incidence of ineffective triggering. Although the cause for ineffective triggering are unknown in this study and it demonstrates the clinical relevance of patient ventilator asynchrony. Measurement of airway resistance and intrinsically may help clinician to understand the reason for failed win. Now, resistance diagnostic approach. Flexible bronchoscopy is the gold standard for diagnosing upper airway resistance. Patient should be disconnected from the ventilator during bronchoscopy so that presence of tracheomalacia can be assessed. Tracheomalacia can be treated with non-invasive ventilation or placement of endotracheal stent. Management of other causes from central airway obstruction is usually evident but is complex in nature. The flow time and pressure time loops provide qualitative assessment of the presence of increased airway resistance and intrinsic peak. Now, the therapeutic strategy in COPD patient being weaned with the pressure support ventilation, appropriate setting of cycle of criteria is of importance to limit intrinsic peak. The work of breathing as demonstrated by uh, Chiomilo and colleagues. Changing the cycling of criteria from 5% to 40% significantly reduced intrinsic PEEP and work of breathing. These effects were most prominent at low level of pressure support. Applied PEEP may reduce the intrinsic work of breathing imposed by intrinsic PEEP. Applied PEEP should match the level of intrinsic PEEP as estimated by expiratory occlusion technique. Patient with asthma and COPD should be treated optimally to reduce the bronchoconstriction. The effect of bronchodilator in patient without history of COPD has not been tested. But if airway resistance appear elevated, latent obstructive airway disease may be present. Attention should be paid to optimal delivery of inhaled medication as this will greatly influence its effect. Clinical studies have shown that in patients with COPD, the bronchodilator effect does not further increase after 4 doses of 100 microgram of albuterol via meter dose inhaler. The effect of 400 microgram of albuterol lasted for at least 60 minutes. The frequency of administration depends on the severity of bronchoconstriction and its clinical effect. The effect of long-acting beta-2 agonist salmeterol lasts for 6 hours. However, it should be noted that maximal bronchodilating effect of salmeterol is achieved after more than 30 minutes and therefore is less suitable in acute setting. As much more experience is available for albuterol in mechanically ventilated patients, it remains beta-2 agonist of choice. Now about compliance. Respiratory compliance is determined by the compliance of the chest wall and the lung. In patients with ARDS, compliance was significantly lower at the time of weaning failure compared with weaning success. The static compliance of respiratory system can be calculated after measuring inspiratory and expiratory plateau pressure and tidal volume. So the compliance of the respiratory system is tidal volume upon P flat minus speed. PEEP. Normal compliance is 60 to 100. Optimizing compliance by reducing edema of the lung and chest wall, resolving atelectasis and thoracocentesis, removing ascites may facilitate weaning. Now about gas exchange. Most weaning patients still have considerable disturbance in gas exchange at the time of weaning and may develop hypoxemia and hypercarbia or both during spontaneous breathing trial. Weaning failure patients are frequently unable to increase minute ventilation in response to high arterial partial pressure of carbon dioxide because respiratory muscle weakness, altered respiratory mechanics, and so on. In this patient, it is important to limit instrumental dead space as much as possible. Now about brain function, delirium and depression in the wean. Brain dysfunction in the difficult to wean patient is related mostly to delirium. Only one paper specifically studied the role of delirium in weaning, and paper showed that impaired cognitive function was associated with more than fourfold higher risk of failed extubation. Other psychological disturbances such as anxiety, depression may interfere with successful weaning. Sleep disruption frequently occurs in ICU patients, but no data showing the effect of disturbed sleep architecture on weaning are available. Now about diagnostic approach, the confusion assessment method for ICU is a well-validated screening tool for delirium in mechanically ventilated patients and is available in the numerous language. But other screening tools have been validated as well. Diagnosing other cognitive disorder in ICU is best performed by psychologists and psychiatrists. In general wards, reducing risk factor for delirium reduces the incidence of delirium. Midazolam is considered risk factor for development of delirium. A recent multicenter trial indicated that sedation with the dexmedetomidine reduces the incidence of delirium and reduces the duration of mechanical ventilation compared with sedation with midazolam. Now about therapeutic approach, high level of sedative are associated with increased time spent on the ventilator. A daily wake-up call and if appropriate, subsequent spontaneous breathing trial are associated with reduced time spent on the ventilator. The role of sedatives in the failed spontaneous breathing trial or failed extubation is less clear. Depression is associated with weaning failure in patients admitted to long-term weaning facility. And preliminary data suggests that pharmacological treatment of depression favors weaning from the mechanical ventilation. Sleep may be improved by limiting noise and light during sleep hours and adequately treating pain and discomfort. The effect of ventilator mode on sleep quality has been a subject of discussion, and difference in outcome are probably related to the level of pressure support. Now about cardiac dysfunction, the transition from mechanical ventilation to spontaneous breathing imposes an additional load on cardiovascular system because of intrathoracic pressure changes which affect ventricular preload and afterload and increase oxygen consumption by the respiratory muscle. So cardiac function during weaning. In patients with the COPD but without cardiac disease, weaning was associated with significant reduction in the left ventricular ejection fraction. And this reduction was probably due to increased left ventricular afterload. Moreover, in a difficult weaning patient with COPD and history of heart disease, spontaneous breathing trial resulted in elevated pulmonary artery occlusion pressure and left ventricular end diastolic pressure, suggesting reduced ventricular compliance. Elevated left ventricular end diastolic pressure during weaning may induce pulmonary and bronchial wall edema and thus increase the work of breathing. Patient with failed weaning, there is a progressive decline in the mixed venous O2 saturation was found. The decrease in SvO2 resulted from the inability to improve cardiac output and therefore oxygen transport. The increased afterload of both right and left ventricle were found in this patient. Brain natriuretic peptide is the hormone released from myocardium upon stretch. In patient with the failed spontaneous breathing trial and failed extubation patients, changes in the BNP are significantly higher than in patient with successful extubation. Now about diagnostic approach. The first step in the to assess cardiac dysfunction as a cause of weaning failure is electrocardiography at final stages of weaning trial to detect ischemia. Subsequently, SvO2 could be used as screening tool for cardiac dysfunction in difficulty weaning. It should be noted that reduction in the SvO2 in normal response to increased loading. In a healthy subject performing moderate exercise, SvO2 decreases below 50%. Accordingly, a decrease in SvO2 should not be regarded as a sign of cardiac failure. On the other hand, in weaning failure patient without reduction in SvO2, cardiac failure is highly unlikely, but rather is the result of hypoventilation, lack of motivation, or cognitive dysfunction. Accordingly, in patients who do exhibit decrease in SvO2 during failed weaning, cardiac failure may play a role, and measurement of pulmonary artery occlusion pressure and cardiac output by means of Swan-Ganz catheter or echocardiography must be considered. Now about treatment strategy in difficult to wean patient with evidence of cardiac failure. Afterload reduction and ultimately the use of inotrope must be considered. Notably, the amelioration of pulmonary mechanics will reduce the left ventricular afterload. No studies have compared the different classes of inotropes in this patient. Levosimendan is the new inotropic agent used in the treatment of cardiac failure. One of the mechanism of action is enhanced calcium sensitivity of the cardiac contractile protein, resulted in elevated pressure generation. Though promising, levosimendan has not been tested in placebo-controlled trial or directly compared with older inotrope in weaning failure patients. Interestingly, it was recently shown that levosimendan improves the contractility of human diaphragm muscle fiber as well. Now about diaphragm and respiratory muscle function. Initiating spontaneous weaning trial puts an acute load on inspiratory muscle. The elevated load is imposed on weakened respiratory muscle pump. When considering inspiratory muscle as a cause of weaning failure, it should be kept in mind that dysfunction of ventilatory pump may result from lesion anywhere between afferent chemoreceptor of respiratory center to the contractile protein. Now the drive, weakness and fatigue. Impaired respiratory drive is the uncommon cause of weaning failure. In fact, in most weaning failure patients, respiratory drive is increased. Occasionally, clinically relevant diaphragmatic dysfunction result from damage to the phrenic nerve. The most frequent disorder affecting the phrenic nerve is the critical illness polyneuropathy. As biopsy studies have shown that critical illness polyneuropathy and critical illness myopathy often coexist, the term ICU-acquired weakness has gained popularity. There is convincing evidence that contractility of the respiratory muscle is impaired in mechanically ventilated patients. Laghi and colleague found that in heterogeneous group of the mechanically ventilated patient, transdiaphragmatic pressure obtained after magnetic stimulation of phrenic nerve was only approximately 35% compared with the healthy subject. Levine and the colleague found that profound muscle fiber atrophy accompanied by the activation of proteolytic ubiquitin proteasome pathway in diaphragm of the patient mechanically ventilated for 18 to 96 hours. Now about diagnostic approach. The diagnostic approach of diaphragmatic dysfunction is sophisticated and in-depth neurological examination should be performed by the neurologist. The most frequent used test to evaluate respiratory drive in mechanically ventilated or spontaneous breathing patients is airway occlusion pressure at 100 milliseconds. So to this end, inspiratory limb of the ventilator is occluded and the drop in the airway pressure is continuously monitored. In normal subject, the P.1 is about zero point 0.5 to 1.5 centimeter of the water. It should be noted that P.1 depends not only on the respiratory drive but also on the inspiratory muscle capacity. Accordingly, the reduced value is not very specific sign of impaired drive, but patient with the normal or high value impaired drive is highly unlikely. So, generalized skeletal muscle weakness will guide the clinician to respiratory muscle weakness, but does not prove inspiratory muscle weakness and vice versa. The global assessment of inspiratory muscle function can be obtained by measuring maximal inspiratory pressure. Lower limit of maximum inspiratory pressure in healthy patient younger than 65-year-old are minus 75 centimeter of water in male and minus 50 in female. Values are more negative virtually exclude the significant inspiratory muscle weakness. Values that are less negative and do not prove muscle weakness, as this method depends on the cooperation and the lung wall. Accordingly, the maximal inspiratory pressure may be useful in evaluating differential diagnosis of difficulty weaning. At this stage, does not evaluate the endurance of inspiratory muscle. The value of maximal inspiratory pressure as a weaning predictor is much more controversial. Definitive diagnosis of respiratory muscle fatigue after trial of spontaneous breathing is not feasible in routine clinical care. The development of hypercapnia during weaning trial is not very specific finding. So the hypercapnia may result from the cause other than muscle fatigue, such as central hypoventilation and rapid shallow breathing. The absence of hypercapnia in the weaning failure patient virtually exclude inspiratory muscle fatigue. Now about treatment strategy. Mechanical ventilation is the double-edged sword for the respiratory muscle. Unloading prevents the development of the fatigue, but inactivity is associated with development of weakness. When considering training schedule, clinicians should keep in mind that diaphragm operates mostly at submaximal force level. Therefore, when clinician decides that inspiratory muscle training may facilitate weaning from mechanical ventilation, from psychologist's point of view, endurance training strategy is most appropriate. Antioxidant modulate respiratory muscle function in healthy patients. Antioxidant supplementation was associated with reduction in ventilator-dependent days from 4.6 to 3.7. Effect of tight glycemic control on clinically relevant outcome parameter. The effect of tight glycemic control on clinically relevant outcome parameter in critically ill patient are complex. Tight glycemic control did not favor weaning and reduced the survival. Effect of the growth hormone treatment. The effect of growth hormone treatment, that is 0.07 to 0.13 mg per kg of body weight, has been reported in two parallel studies published in 1999. In addition, growth hormone is increased time spent on the ventilator. The safety of growth hormone supplementation in weaning patient is unknown. Now, endocrine and metabolic dysfunction. The role of endocrine disorder in a difficulty weaning patient has gained little interest in the literature. For a variety of reasons, including decreased central drive and the respiratory muscle weakness, hypothyroid may delay weaning from the mechanical ventilation. Malnutrition frequently occurs in mechanically ventilated patients and is associated with the poor prognosis, but also with the reduced muscle mass and as such contribute to the difficult weaning. So the nutritional status should be evaluated by determining body mass index, plasma albumin concentration, and nitrogen balance. Ideally, energetic need should be determined by indirect calorimetry to prevent under and overfeeding. Electrolyte abnormalities, including very low plasma level of phosphate and magnesium, has been shown to affect skeletal muscle function. Although these should be corrected in difficult weaning patients, no studies have investigated the role of electrolyte abnormality in the weaning failure. Other metabolic disturbances that increase the risk of breathing that therefore be associated with difficult weaning include metabolic acidosis and fever. So these are the weaning indices that we should follow while weaning. Tidal volume should be at least 5 to 6 ml per kg of body weight. Respiration should be regular without period of apnea. Respiratory rate should be less than 35. Minute ventilation should be less than 10 liter. Hyperventilation of more than 15 to 20 liter per minute has high chance of weaning failure. RSBI index should be less than 105. Diaphragm strength as assessed by maximum inspiratory pressure after 20 to 25 seconds of tube occlusion with one-way valve is less than should be less than minus 20. Neural drive, that is P zero point 0.1 to Pi max, should be less than 0.3. Integrated index should be more than 30. Thank you, guys.